Okie dokie. Well, thank you everyone for being here today and coming to my talk. So my talk's combining principles of human-computer interaction and patient and public involvement to understand patient lived experience. A case study in self-tracking bipolar disorder. So I thought I'd kick it off kind of talking about who I am. So my name is Shazmin Majid. I've got a bachelor's in psychology, a master's in psychological research methods, and I'm going to shamelessly say that I've almost got a PhD. Just need to submit my thesis in a few months. So my PhD is in HCI, human-computer interaction, focusing particularly in sort of UX methods in healthcare. In the past, I was a UX lead at a company called Blue Sky AI, and we very much created technology within the healthcare sector to leverage AI to understand mental health and physical health. But what I think is quite notable is that prior to all these experiences in technology, I primarily worked in the healthcare sector. So I've had various different roles, such as assistant psychologist, research assistant. I also worked as a healthcare assistant. So very much sort of frontline healthcare, particularly in mental health. So yeah, it's been really interesting having that experience and then making the transition into UX. So a lot of the experience that I'll talk about today is very much guided by my previous experience before moving into technology. So let's kick off with a little bit of an introduction. So UX in healthcare. This has been the burning question for me throughout the course of my PhD. And that is, how are we actually involving the user in research and design within the context of UX and healthcare? Because coming from this different background of healthcare and understanding now the tech sector and UX, I understand that we have different methods in the way that we involve the user, right? So I want to dig a little bit deeper into that. Now, within healthcare, we have approaches called patient and public involvement, PPI, right? And these are methods in which to involve a patient or a member of public within, especially within the context of research. So I thought I'd delve into that a little bit, just in case we don't know what this means. But PPI traditionally has an evidence base in mental health research. And unlike the approaches we see in UX, PPI is traditionally quite linear. So imagine you have a research project, it has a start, it has a middle, it has an end, and users or patient or members of the public are involved in discrete parts of this in order to guide the research. They may partake in the research, but very much around orientating that research around them, okay? And like what we see in UX, it's very common that a clinician will be the one leading the PPI and leading the integration of patients and members of the public. Also, just like sort of tech-based approaches, involvement is very much on a continuum. So we have, low involvement, medium involvement, high involvement, and high involvement is very much empowering the user to maybe autonomously manage the research, right? But that is very seldom seen. So high involvement is something that's not very much seen within the healthcare sector. It's more sort of medium to low involvement. It's also very common that users are paid for their contribution, and they're also very commonly authors on any published work, especially as a last author, and they're very much involved in kind of drafting transcripts for publication. And when we're thinking about PPI within the context of technology, it's a common method that's used in more technology assessment So think about sort of involving PPI members in assessing the ethical risk of a technology or any sort of risk factors. That's very much when this approach has been used, which is what I've seen within the literature. I won't spend too much time talking about how much we involve, what the methods are of involvement within UX. We all have a developed vocabulary. Let's say we've got user-centered design, human-centered design, participatory design, so on, right? So we have a very enhanced vocab, but very much so it is an iterative process, okay, of involvement throughout the development of a product. There is much more of a focus on participatory approaches. And unlike PPI methods, those stakeholders, such as clinicians or maybe carers, may be involved in that process. They're not the ones that are necessarily leading this. And of course, within UX, human HCI approaches are able to measure and observe these more nuanced understandings of technology, such as UX, whereas PPI is very much focused on sort of developing research. So their use cases are very different. However, they have very much a commonality. At the essence, both approaches urge for the involvement of users in research and development. They focus on understanding and empowering users, and of course, making changes based on user feedback. But I won't just leave it there, because I was really interested in understanding this within the context of my PhD. And now my PhD is about designing and developing self-tracking technology in the context of bipolar disorder, okay? And what I wanted to understand is, okay, we have all these approaches, we've got PPI and we've got all the stuff in HCI, but really what's happening when we're designing technology, especially within the context of, say, mental health? So I did a literature review, and this got published last year in the Journal of Medical Internet Research. The DOI is there if anybody wants to check it out. And I investigated 3 particular questions to understand. And that is, are users being involved in the design and evaluation of technology? If so, how does this happen? And what are the best practice ingredients for the design of mental health technology? Because, of course, designing within healthcare, or especially within mental health care, you have this intersection between healthcare and technology. And it's very much a new and emergent field. So there isn't necessarily these best or better practice ingredients. And I really wanted to start opening up that conversation as to what does a gold standard look like? What does better practice look like? Because I struggled to find that in the course of my PhD to guide me. So I investigated this via a literature review, and we then put the best practice ingredients via an expert panel review. And the expert panel review consisted of me and a professor of HCI, a psychiatrist, a professor of human factors, and somebody with lots of experience of PPI methods, as well as a user who had lived experience of bipolar disorder. So what did we find? I'm always biased to say that we found some really, really cool stuff, but we genuinely did. So we included 11 novel self-tracking applications in this review. And we kind of assessed these in terms of levels of user involvement. And we found that 36% of them, were classified as having no user involvement whatsoever in the process of design and research. We found that 1 was classified as having low user involvement, 4 were classified as having medium user involvement, and 2 were classified as having high user involvement. So what's of note here is that one of the lowest scoring categories is that of no user involvement. And we only had 2 who were classified as having high user involvement. Even though there being recommendations of user-centered design within sort of NHS digital, you can see here that the involvement of users in this context, which is severe mental health and technology, that the involvement of the user is highly, highly variable. So just to expand on that a little bit, the conclusion we made here is despite the presence of extant approaches to involve the user, there is large variability in whether the user is involved, how they are involved, and to what extent there is a reported emphasis on the voice of the user, which is the ultimate aim of such design approaches. So high user involvement here was classified as some mention around the empowerment of the users. And we only found that 2 novel self-tracking applications made some mention of this. So yeah, we can see here it's super, super variable. So of course, there's no time like the present to kind of put forward some better practice ingredients. So I've put all 7 onto the slide, just FYI, but I know it's a lot of text, but I want to focus particularly on the 2 that are in bold. So, of course, we make recommendations that we should involve users in all stages of design and evaluation. This includes concept generation and ideation, prototype design and deployment, and evaluation, with the goal to create user empathy and/or empowerment. We found that those studies that did involve the users had super small sample sizes. So we also urged that there should be an adequate number of participants in order to welcome diversity in thought. We should have a generalizable sample, and equal representation is also a crucial consideration that needs to be considered when recruiting users. And in line with the title of this talk, we suggest that there should be a mixing and matching of methods. So just to draw you to point 3, we recommend that practitioners combine principles of PPI and HCI to not only have users to assist in designing technology, but also designing and running research. And I'll just pause here because this can seem very complex, but okay, we're involving users in the process of design, but are we involving users in the process of designing the research that underpins that? As UX practitioners, we ask questions, maybe what are your everyday experiences of using X or Y? But have we ever stopped and thought about how to ask these questions? Have we involved users in the process of designing those questions? Touching base on terminology or maybe tone or these kinds of things. And I realized that in the process of designing these better practice ingredients. And another example is, okay, we run design workshops. Have we ever thought about involving a user in maybe co-facilitating that to see whether it makes any difference? So what I'm urging for is end-to-end user involvement. I'm not going to sit here on my high and mighty horse and say this is easy. It's not, of course, especially within the context of mental health care where there's ethical issues, it's difficult to access target populations. I understand that. However, we did very much try and practice what we preach in this case study. So I'm going to go back and let you guys know how we did that within this research. Okay. So here we go. An attempt to practice what we preached. Another paper I got published very recently in ACM's Designing Interactive Systems, which was literally last week, was around putting what we preached in the review into practice. And that paper was titled Exploring Self-Tracking Practices for Those with Lived Experience of Bipolar Disorder learning from combined principles of patient and public involvement and HCI. So what we did is we explored the following. We explored reasons for self-tracking, methods for self-tracking, and challenges and opportunities for future technology. So essentially, it was very much a discovery piece, but a discovery piece that combined different methods of involvement. So how did we do this? I guess this is the most interesting part. So we had 5 different research items. For those research items that have a circular icon in it, that was something that we described as a patient and public involvement method. And those that have a triangle are what we would have considered a human-computer interaction method. And the 7 principles that we harped on about in our previous review are also indicated at the start of the research items. So I'll just walk you through what we did. So at the start of all of it, we met with 2 users who have lived experience of BD, of bipolar disorder, to design the process and design the research. So we collectively designed the workshop schedule, the recruitment strategy. We talked about where we would run further research because we were running some workshops, how we would analyze the data. Everything was considered, and we scoped out the research. And I'll give you one kind of poignant example of something that happened. Now, this research was very much sponsored by the universities. It's part of my PhD. So it made complete sense to me as a researcher to run these workshops at a university setting, right? You know, costs would be low and it would be within campus. And I spoke to these 2 users with lived experience, and they said to me, I don't think that's a good idea. And we discussed this, and they said to me, actually, people who have severe mental health, and if they come to a university setting, they might associate that setting with a more clinical setting, or maybe their responsible clinician may have some relationship with the university, so they may feel like they can't say everything they want to say, or, you know, all these kinds of things around probes, around a more professional clinical environment. But we wanted to create a more relaxed environment where people felt like they could share about their everyday experiences. So instead of running the workshop at the university, we ran it in a more relaxed setting. One was ran in an event room at a coffee shop, and the other one was ran in a meeting room. So this is just one example of how the research changed just by having those users with lived experience designing the research with us. Moving on to item 2, we recruited participants from local and national charity organizations. And this was with the assistance of those 2 users with lived experience, because these organizations were very much patient-led. And by making the case that our research was also patient-led meant that we were able to access these organizations, and they were also advocates for our research. Then on the day, number 3, we ran the workshop. So we ran one in Nottingham and one in Northampton. And we had 18 participants who attended. And what we did here is those 2 users with lived experience co-facilitated the workshop with me in order to create a more peer-to-peer environment where people felt comfortable to share. Then we ran some follow-up interviews with 10 users who attended the workshops just to kind of understand the findings a little bit more. And then we collectively analyzed the research, mainly sort of thematic analysis. And then we presented the findings back to those participants that attended the workshops and created another sort of loop of iteration. I did a presentation and welcomed feedback before we finalized the results. So what did we find, which is the most interesting, I guess? So here, we explored reasons for self-tracking, right? And we were able to understand different themes around self-tracking. So it was quite detailed, the findings. We were able to categorize some discrete themes, and it's worth mentioning here that these are themes that the participants themselves came to in an affinity mapping exercise. And importance was also indicated by dot voting. So we've got some themes around how does self-tracking help you, and so forth. So where I've put the little light bulbs here that are flashing away are the most important findings for us. So what we did here is we compared what we found to other similar studies within the literature. And indeed, we found that the social and communicative elements of self-tracking were found to be super important. And this was in line with similar research findings. However, when we looked at other research findings, we found that when participants described this social and communicative element of self-tracking, they very much described it in a way of benefiting their clinical relationship. So sharing their experiences of self-tracking, or maybe their findings from self-tracking, with their clinician or their nurse or members of their clinical team, right? But as you can see on this particular slide, sharing with health professionals was very much at the lower end of the scale. When participants described the social and communicative elements here, they very much talked about their relationship with their family, with their friends, with their loved ones. And there was no mention of health professionals. So we concluded here that maybe by taking the research away from a more clinically or an environment that may probe a more clinical relationship, or maybe removing some elements of, say, social desirability, we were able to uncover a difference in the findings and maybe uncover more of a reality of what self-tracking meant to people. So I'd like to just put across some benefits of using this approach. Number one is that we hope that we were able to uncover rich details and findings that are led by the first-hand lived experience of the participants, which in turn can, of course, appropriately guide mental health technology research and design. We hope that by involving users in the process of designing the research, we were able to create a more neutral, open research and design environment, which allows participants to feel encouraged to share, remove from expectations, fear, or judgment. And another thing that I particularly am really proud of about this research is that I hope I was able to empower users to guide the research and design by experience. I had lots of conversations, especially with these users who have severe mental health issues, and just their experiences of feeling disenfranchised or feeling like their voice really didn't matter, not just within sort of UX, but just within their experiences of healthcare generally. And to be an advocate of their voice was something that was a complete honor for me. And I hope that it's able to be a good example of why that's important, because at the end of the day, they are the experts and we are just there to advocate for their experience. So what else did we find? I thought I'd touch upon some methods for self-tracking as well. So unlike other research that we found in this domain, we were able to uncover some super complex and very detailed findings around methods, right? So just like other literature, we found that methods of self-tracking fell into different categories, and they were very similar to what we saw, things around pen and paper methods of self-tracking, using mental notes, maybe social feedback, and technology-based. We found 50 methods of self-tracking. So participants talking around, in total there was 50 methods. But what we uncovered here that was really interesting is, indeed, we know about the methods, but what is the experience of using them? How do they count things or make sense of these self-tracking methods? And one thing is around, of course, you know, mood and mental health are very much qualitative life experiences, but how do you convert that into something quantitative, which is very much the essence of self-tracking and this whole kind of discourse around the quantified self? And I'd like to draw your attention to quote number 2 in Mental Notes. And that is, somebody said to me, if I make a list of 20 things to do, if I get at least 5 done, then that's good. Okay. We all have maybe Apple Watches or Fitbits, right? And they are very much geared towards goal completion at 100%, right? You set a goal and you have to complete it at 100% for your Apple Watch to give you a little bit of a buzz to say, hey, you've done a good job. But within the context of mental health care, maybe this is very different. It seems in this case that completion by, say, 10% was considered to be successful for somebody. And therefore, the whole notion around what constitutes success within self-tracking maybe needs to change and maybe needs to be a bit more idiosyncratic. So from these findings, we were able to make some quite in-depth recommendations for self-tracking. As you can see here, people have methods that are more qualitative, such as social feedback. And some people have the more quantitative methods of self-tracking, such as the quote around making a list of 20 things to do. So we should be providing the user with choice as to whether self-tracking technology, such as tasks and feedback, is quantitative or qualitative focused. Numbers mean different things to people, as we can see again from the quote around making a list of 20 things to do. Therefore, users should be able to define the quantitative if needed. For example, many self-tracking technology for BD provide things such as scales, scales between 1 to 3 or maybe 1 to 10, right? To score mood. And I found in this research that, hey, I might like scoring my mood using numbers 1 to 3. That might work for me. But you might like 1 to 10 because it provides you with more scope around scoring your mood. So people have different preferences. And what numeric success means to people is different, as we can see from the quote there, where it says, making a list of 20 things to do. And if I do 5, then that's good. So it's not always around 100% completion, but very much about understanding what success means to somebody and tailoring technology towards that. And then the last recommendations that we put forward is that users should have the ability to augment quantitative data with a qualitative experience in order to provide a more rich understanding of what the quantitative data means. So that was our last recommendation, and that is the end of my talk. So I would love for any questions.
Okay, so I just wanted to check from the auditorium if there was any questions, any comments at all. Nothing? There's one. Thank you.
Hi, thank you for the presentation. I have a question regarding when you talked about best practice ingredient for research involving mental health. You said something about using generalized sample, and I'm just thinking about that in the context of UX research. So, for scientific research, I believe we understand the rigor that is involved in having a generalized sample size and what that entails and the probability and all that, procedure. But typically in research, UX research specifically, there's a rationale around, using very small sample size, and you keep iterating till you feel comfortable that you've captured as much information as possible. So I would like to, get your own view. How do you from your own study, how do you think in UX research you can actually achieve a generalized sample of a population you're designing for?
Sure, yeah, of course, it's a really good question. Thank you very much. So when we looked at the research, we found that some research studies only had a sample of, say, 1 or 2 users, right? And we argue that that, of course, isn't enough to understand the whole experience of something as complex as severe mental health. I think what's really important, especially within the context of involving users in the context of UX in mental health, is that to have users that are maybe at different stages of recovery, which is really, really important to represent, because if somebody is kind of in remission in the context of mental health, their experience is going to be super different compared to somebody who is maybe experiencing, say, an episode, or is very much at the start of the journey of getting there. So to make sure you're aware of that as a UX practitioner, and that you're not drawing all your findings from essentially a pool of participants or users that are essentially well, is really, really important. It's just having kind of a mindfulness around that, which is completely different, say, UX in other contexts where having 1 or 2 participants is different compared to that in healthcare.
Great. So, I think that's any additional questions from the auditorium? No. And then just one last round for the virtual guys. Any questions from that side? I don't see anything in the chat, so I think we'll just wrap it up and say thank you very much. We appreciate so much that you've taken the time to join us. And I think the virtual thing worked for this session, so thank you.
No worries. Sorry, guys. I got COVID last week, so better safe than sorry. But thank you for your time, and thank you for listening to my talk.
Hope you feel better. Thank you.